I'm going to share my screen. Okay, sorry. I'm going to share the screen again. Okay, so this is what we are doing today. Please, can you see my screen?
Yes, please, but it's not in presentation mode.
Okay, sorry. Okay. Okay.
Thank
So,
you.
yeah. So, please, we are going to. I hope you have gotten your biscuit or drink water to use for this presentation. So we are going to talk about dysphagia in adults and in children. And in this lecture, I would like you to go home understanding dysphagia, the causes of dysphagia, persons that it affects, the symptoms that we can see, and then how to manage dysphagia. So before I start dysphagia, I would like us to know swallowing first. It's also called deglutition, but I would like us to know what swallowing is. So when we treat swallowing and then I get to dysphagia, you will get to understand it more and appreciate it more. So we'll just do this swallowing first, then we'll go to dysphagia. So first of all, we know that we like to eat any food, our pizza, our drink, wache, beans, and it goes down easily. So the act of allowing food to go down, the act of allowing food to go down or drink to go down to pass through your throat is just swallowing. That's the easiest way or layman's way to explain swallowing. So I will show a video for us to appreciate swallowing more. And after the video, I'll take you through the phases of swallowing, and then you would appreciate it more. So please, I'm going to share my video. It's just a very short video, like 2 seconds video. Okay, please, can you see my screen?
Yes, please.
Okay, so this is a very short video of swallowing, like normal swallowing. Just take note of what is happening. Then I'll go back to the slide, talk about the phases of swallowing, and then we'll come back to the video again so that you can apply what you learned in the slide onto this video. So first of all, we'll watch the video. Okay, it's going to come again. So this is normal swallowing. Whenever we swallow, whatever that we eat that we swallow, this is what happens to the food. It just goes down. Okay. So I'm going back to my slide. I'm going back to my slide. Okay. So we have phases of swallowing. So first of all, we have the oral preparatory stage, the oral phase, the pharyngeal phase, and then the osopharyngeal stage. There are 4 phases of swallowing. The first phase is where we are aware that food is about to enter our mouth. So maybe you are holding, I have my bottle of water here. So this is just oral preparatory phase, okay, where we are aware that food or water is coming. So the brain is giving signals that food is about to enter the mouth. And this phase is voluntary, very voluntary. And the second phase is the oral phase. And this is stage that the food has entered our mouth. This time I want to have water here. I've swallowed, but that is not bad. So the oral phase, this is where food has entered the mouth. And then when food enters your mouth, your lips are sealed, you start chewing, saliva is mixing the food so that the food becomes soft enough for you to swallow. So at this phase, this is what happens. Your food is turned into a bolus. So this time around, it's not food again, it's called bolus, bolus. It goes into the mouth and then going down. So at this stage, the mouth is sealed, chewing is happening, saliva is mixing the food for it to go down easily. And then the third phase is the pharyngeal phase, which is very involuntary, like voluntary movement stops here. So here, swallow is triggered, and then the food moves from the mouth to the oropharynx here. And at this point in time, I want you to know that your breathing ceases. When you are breathing, your breathing ceases at this point. So the food is able to go down to the esophagus. And then the last phase is also involuntary. This time around, the food is going down to the stomach. And when the food is going down to the stomach, there is a process called peristalsis. Yeah. So this is where some muscular movement around the esophagus pushes the food down into our stomach. Please, is it okay? So after appreciating these phases, I want us to go back to the video and we'll apply all the phases that I have mentioned here. Okay. So when I started, I was saying the oral preparatory stage, which is here when the food is just about to enter the mouth. And when the food enters the mouth, this is the oral phase where food is being chewed, saliva is mixing the food to make it soft enough for us to swallow. And then when swallow happens, this is where the oropharynx is. This is the oropharynx area. Food is transferred from this side to this. And this side, when food gets here, it's automatically going to be, there's a swallow trigger reflex here, which goes down. And when it comes down here, this is the esophageal phase where food is pushed down to the stomach. But I want us to look closely at what is happening in this video again. Okay, so we realize that food is going down slowly. The epiglottis is closing the trachea. This place is where air or respiration happens. So breathing in and breathing out this side. So it's closing the vocal folds here. This is the epiglottis, which closes our airway, and then allows food to travel down the esophagus, and we see peristalsis happening. There's some logology thing happening here. That's peristalsis pushing the food down. And you also realize that this side to the soft palate also closes. This is the nasal cavity. So it closes off the nasal cavity. So the food will not move from this side to come out of the nose. Okay, so I think you're appreciating swallowing now. Okay, let me stop my video and move on. So I'm sharing my slide. I'm going back to my slides. So as we watch the video, I hope you appreciated the various phases of swallowing. Okay, so I would like us to also take any bottle of water that we have or biscuit, and let's try eating something and experiencing how swallowing will go about. So first of all, we are breathing already and we are anticipating the food. I've gotten my bottle of water. The food will enter into my mouth. And this is water, this is no food. So the moment water enters into my mouth, there's a lip seal. It finds its way for a swallow trigger for it to go down. And before I swallow, there's a period where I stop breathing, which is called a period of apnea. So I have to stop breathing for the epiglottis to close my airway, and then the food will go down into my stomach, and then I start breathing again. So that's why we are told not to talk whilst we are eating. So in this swallowing process, there are some nerves that are involved. I'm talking about nerves. I'm sorry to go into neurology, but I'm just mentioning them. You just have to, I want you to know so that when we get to dysphagia, you understand what I'm going to say. We have some nerves that are responsible for swallowing. We have the cranial nerves, 9, 10, 5, 7, and 12. 11 and 12, which is the glossopharyngeal, the vagus nerve, the trigeminal nerve, facial nerve, the spinal accessory nerve, and the hypoglossal nerves. So these nerves, they coordinate the voluntary and involuntary muscle movements of the mouth, the pharynx, the esophagus, allowing the safe and efficient passage of food from the mouth to the stomach. So these nerves are very, very important. I would like you to keep them in mind. When I get to dysphagia, I'll come back to them for you to understand more. Thank you. So what are the areas of the brain that are also involved in swallowing? Remember, I told you the brain always gives a signal for swallowing to take place. So the brain stem is very important in swallowing, the cerebral cortex, and then the cerebellum. All these are the areas of the brain that are involved in swallowing. If they are not there and they are not functioning, then something is happening. So I want us to also take note of these areas, and I'll come back to them when it gets to dysphagia. So why is swallowing important? So it's very important so that we'll eat and drink and have our nutrition, have good nutrition, have good balanced diet. If we don't swallow, we can't have all of those things. And when swallowing also prevents liquid from entering our lungs, and we have a good quality of life where we enjoy meals with our friends, we go to parties, we are swallowing, we are talking, and we don't have any issues with swallowing. So swallowing is very important part of our diet, and we have to really take note of it. So now we are going to dysphagia, why we are here. We are going to talk about dysphagia. And what do we say dysphagia is? So dysphagia is difficulty in swallowing food, drinks, and saliva. Remember, swallowing allows food, drinks, and saliva go down easily, but dysphagia is a condition where food, saliva, drinks cannot go down easily. And it is not a disease, but it's a symptom of another condition that someone might be having. That's why they got dysphagia comes along. And dysphagia can kill. It is not a play thing. It can kill. So I would like us to take that one too seriously. So I have a picture here to show you normal swallowing versus some swallowing difficulties. So we have the mouth, and this structure here is the tongue, and this is the trachea, this is for respiration. Epiglottis, this is the epiglottis, this thing there. This thing there is the epiglottis, which is closing the trachea. And our esophagus, we saw in the other video. So with normal swallowing, realize that food is going down easily. One logo line here. But here, we realize that food is passing somewhere where it's not supposed to pass. And this is our respiratory area where we take in air. So food is entering into this area. And this is another aspect of dysphagia. This is not all about dysphagia, but this is just an example of what can be happening when someone is not swallowing well. Okay. So what can cause dysphagia? What causes dysphagia? So dysphagia involves many muscles and nerves, as we talked about earlier on. So any condition that weakens or damages these muscles and nerves can cause narrowing of the throat, which is the esophagus, or can cause dysphagia too. So some examples, we have stroke and brain injury. And we know that stroke is the damage in the brain where there's an interruption of blood supply. So stroke, if they damage some parts of the brain, and you know I mentioned some parts of the brain that are involved in swallowing. If some parts of the brain, if some parts of the brain are if some parts of the brain are injured through stroke, dysphagia can occur. Brain injury can also cause dysphagia. We have some neurological diseases like Parkinson's and ALS. And we know Parkinson's is a condition of the brain that causes problems with movement. Okay, movement that causes movement. So if we have some if neurons on this part of the brain, they become weak. The neurons in Parkinson's, when someone has Parkinson's, neurons in their brain, some of them are weak, some of them are dying and will surely die. So it's a progressive condition. It's not as if something that happens and goes. So that's Parkinson's diseases. It can cause dysphagia. Head and neck cancers too can cause dysphagia, especially when you have a tumor growing around the neck area. So when the tumor grows and keeps growing, when tumor keeps growing bigger, it pushes against the pharyngeal wall or the esophagus, the area where the oropharynx, it pushes against that side, narrowing the space there, and it affects swallowing. We can have some tumors on the tongue too as well. It's all about head and neck, all this side. Anything about this side that has a tumor can also cause dysphagia. And age-related changes. When people grow old, there's some weakness in their muscles. There are changes in dentition. They can't chew well. Oral hygiene is poor, and their tongue and lips and jaw are not moving like the way they used to be when they were young. So maybe things could be a little bit slow or weak. So these things can also cause dysphagia. And we have developmental conditions in children too that can cause dysphagia. So some developmental conditions that can cause dysphagia, we have cleft lip palate, which we all know, where we have some kind of gap around this side or at the palate, at the top of the mouth. We have neuromuscular diseases like pediatric stroke, which I have seen before. I think when we went for our Go North, I saw one child with a stroke. Yeah. And then we have cerebral palsy, also is a condition, it also causes dysphagia. I've mentioned about cancer and tumors already. So chemotherapy, because people who have cancers go through chemotherapy and some have surgery. So some of these things can cause dysphagia, craniofacial abnormalities, large tonsils in children, and then being born prematurely. Some things when you are born prematurely, not everything is matured well for the child, so the child might be struggling with swallowing food in the early stage. So I would like to talk about the signs and symptoms of dysphagia. When someone is having or struggling with swallowing, what are some of the signs and symptoms that we can actually see? So we would realize that the person will be coughing or choking while eating. I'm not saying that every time that you eat or when you choke, that means you have dysphagia. No. You realize that this is consistent. It happens every time, every day, in the morning, afternoon, anytime the person is drinking or eating, taking water. Anytime the person tries to eat, there's coughing, there's choking. Okay, that is what I'm talking about. I'm not talking about a one-time thing. And then the person tells you that there's a feeling that there's something sticking in the throat, that there's something there in the throat. So when someone makes such complaints, we have to take it seriously. And then there's excessive drooling. Excessive drooling. I'll talk about that. So excessive drooling is when children swallow coins. We do. I've seen cases like that at Kolebu where we have cases children are admitted because they swallowed coins, batteries, pegs. The pin that is inside pegs. Yeah, children swallow it. So when you notice something, they drool excessively. It's not someone who already drew. So that this is someone who does not drool, and all of a sudden there's drooling taking place. Then you should. It's a sign that maybe they swallowed something they are not supposed to swallow, and then it's stuck in there. So another symptom is that you realize that you are feeding this person, or this child is eating all the time, but unexplained weight loss. I'm not trying to say that if your child is slim, that means the person is having dysphagia, but this one is another way, and this one can be detected by some when you report with dysphagia. I'll go to that slide and you see, but unexplained weight loss because food is not going into the stomach, is going somewhere else. So recurrent chest infection from aspiration. I'll talk about aspiration as I go to further slides. Realize that the person is eating slowly. I'm not saying that a child that is eating slowly already has dysphagia, but you know that this child eats better and eats well, but all of a sudden there's some discomfort in eating, doesn't want to eat, eating slowly. We should take notice of that. And then complaints of pain when swallowing. When anyone complain of any pains when they are swallowing, kindly take it seriously. So there's this gagging effect. We are continuing gagging effect when they are eating. The person gagging means want to throw up, the feeling of wanting to throw up. Yes, and trying to swallow. And when the person tries to swallow one mouthful, like the person swallows several times. When you put your hand there, it's just one swallow, but the person swallows several times. Like when you put your hand there, you realize that swallowing is still taking place. Like meanwhile, we just swallow one food just once, but the person is swallowing more than once. It's also a sign of dysphagia. And having food come out of the nose during and after feeding, which happens with cleft, yes. And then when someone finishes, when there's a wet and raspy voice during and after eating, it's I don't know if you've choked on food, but you see when you choke on food and you cough, your eyes are wet, you realize that your voice is sounding differently. That's that kind of, but this person has it all the time. Ours is maybe once a while choking, we were eating and we were talking at the same time and then we choked. But this time around, and that you have this wet eyes, your voice changes, that feeling, yes, that person has it all the time. So that's when you can say that there's a symptom there, there was a sign. And sometimes with old age, when you are feeding them, they are not alert. That means remember the phases of swallowing, which is the oral preparatory stage. It's not even there. They are not even alert. They are not even aware that you have put food in front of them for the brain to tell the nerves that, okay, food is coming, prepare salivary glands and everything. They are not aware. They are not alert that food is about to enter the mouth. So we have to take note of these signs and symptoms. So who can be affected? Children can be affected. Children with cerebral palsy, adults can be affected. The elderly too can be affected because there are for the elderly, natural changes in swallowing happens because of their age. So some complications if it's untreated. We have malnutrition, poor nutrition. You realize that the person is still losing weight. There's dehydration. And then I spoke about aspiration. Which is aspiration, pneumonia is different from aspiration. So when food goes down to your vocal folds, it's called aspiration, where you cough and then you're okay. But when it causes, but sometimes people do not have the cough reflex. Sometimes it's very silent, like the food has gone into the trachea. So aspiration, when food gets into the trachea and you're not coughing out, no one knows that something is happening. It's a silent aspiration. That one kills easily because there's no reflex to show that you have consumed food into the trachea. And the pneumonia bit comes in when aspiration causes infection in the lungs, and this can kill you. So that's why I'm saying that dysphagia can kill, and this is one of the ways that dysphagia can kill. Thank you. And then you have a reduced quality of life. Reduced quality of life. Everyone is eating, enjoying their pizza, their shawarma, and swallowing easily. And only you have to do some things, change your diet. Even maybe you be feeding through tube. Like you won't have quality of life that would like the way you used to have. And I know that that can be very worrisome. So it boils down to how dysphagia is managed. How do we manage it then? If we are talking about dysphagia, the difficulty of swallowing, then how are we going to manage it first? So first of all, you go through assessment. You have some swallow assessment. There'll be treatment by a speech and language therapist. You have some modified foods and drink textures and compensatory strategies like your posture and medical or surgical options. But I would like to say that with assessment, when dysphagia is being managed, assessment involves a lot of steps and processes. It's not an easy thing because there are going to be a lot of tests and test evaluations to show that actually this is happening. Dysphagia is actually happening. So first of all, when a patient will take the history of the patient, would evaluate the facial muscles, whether there are any paralysis, the vocal quality of the person. Like I said, some of the symptoms is that the person has this wet and raspy voice. We'll take that. We'll check whether the person is swallowing well. So I told you that when someone is swallowing and puts food into the mouth, the person swallows more than once. So when we put our hands here, realize that you're swallowing more than once, realize that, okay, then something is happening. So we'll try different food consistencies. Some people can aspirate on water, but will not aspirate on cocoa or maybe solid food. So the people say that some people will complain, oh, whenever I drink water, I'm coughing. Whenever I'm drinking water, I'm coughing. But when I eat solid food, nothing like that happens. Some people too will cough on anything, any other thing. So we'll check all of that in assessment. And sometimes too, after this bedside assessment, we call this bedside assessment, but we have another assessment where we would do imaging, like we have the flexible endoscopic evaluation where we put, there's this flexible tube. It has lights at the end, which will take it through your nose to find out whatever that's happening when you are swallowing. And then we have the barium test too as well. So all this you go through all these things to check what kind of dysphagia you are having. So dysphagia also, when we are managing it, it depends on the symptoms presented. Your age is also considered. General health of the person is also considered. So when you come, for example, and maybe a child presents with fever, okay, and has trouble swallowing, so it could be a sign of infection. And this one, when they are going to treat it, they'll just give you medicine to heal the infection that is happening. So I'm not saying that every child that has fever is having dysphagia, but I'm saying that a child that has dysphagia and has trouble swallowing. This one, the doctors are the ones that take care of it. ENT doctors and ENT doctors are the ones that do this. They are the ones that administer, or any doctor. So, and the second one too, another dysphagia too is maybe a child swallows an object. There's excessive drooling, they don't want to eat, and then there's this gag effect. Okay. So swallowing an object like this is treated as an emergency case. It's treated as an emergency case. So in this case, the treatment that is going to be done on this child is that the child will go through endoscopy to remove the object that is stuck in the throat, which I mentioned earlier that children in Kolebu always, most children report in Kolebu that they swallowed either the coin, they swallow batteries, and then maybe some time ago, there someone even swallowed crab. You see the crab leg, the one that has done like 7. Yes. I was shocked that how can someone swallow something like that? And then there was a child who swallowed meat. Why did you swallow the meat? The other sibling wanted the meat, so he swallowed it fast enough so that the sibling will not get some to eat. And then he ended up in the hospital. He was choking. So I want us as parents, we should be vigilant to know the time of things that are around. The batteries and the coins are a lot, and the batteries, as in the round ones, we have the round batteries, very, very small. Children like to swallow that a lot. So I want us parents to be aware of that so that we can protect our children. And when there's something like this happens, the children will be under anesthesia, and then as an emergency case, it will be taken out. So another way of managing this esophageal stricture, like I said, this one is surgery, where maybe in all their findings and assessment realize that maybe this part of the esophagus is very narrow, and so maybe they will have to do some dilation, maybe opening it up a little, and this is done through surgery. So this is another means of managing dysphagia. But when we have chronic dysphagia, like the one in stroke, we speech therapists and occupational therapists work together. Which one is a multi or everyone is in charge. The speech therapist, the nutritionist, the occupational therapist, we all come together to help persons like this. So the speech therapist and the occupational therapist will teach some exercises or some compensatory strategies to better allow them to swallow well. And then the dietitian will also come in maybe to talk about some food textures that we have to modify. So maybe instead of eating the meat and it's solid and then you cannot swallow, maybe you puree the rice and meat and everything to make it more. I think some people can swallow it in that texture than in the solid texture. Some people too cannot take water, so there is a way of getting them to dehydrate. There's a way of getting them to hydrate to have their water. But in severe cases where they cannot feed at all or swallow at all, we resort to tube feeding. Like you feed through the tube to allow you to have your nutrition well, and you can also have your water to dehydrate well. So that's some of the ways that we can manage dysphagia. So with the role of the speech and language therapist in dysphagia, we'll assess, like I said, the bedside assessment, we'll check how you are swallowing, some paralysis in the face, and how you are alert when the food is in place. So we'll do some assessments like that, or the endoscopy in Ghana is usually done by the ENT doctors, but outside I heard that outside the country, like the Europe, speech and language therapists are able to use the laryngoscopy to detect or assess. And we are able to provide therapy to improve safety. We will teach you some exercises or some compensatory strategies for you to be able to swallow well. And we educate parents and family and caregivers of persons that maybe are having stroke on how to feed them and how to sit and care for them in this phase. So with speech therapists, we work in hospitals, clinics, and communities as well. So if you want to support someone with dysphagia, first of all, you have to allow extra time for meals. So when you feed the person, you wait. I know it's very difficult for the caregiver, but you have to wait for the person to chew, swallow, and then you give the person the next spoon. So you have to encourage someone to sit in a very upright mode, posture like this, to be able to feed. And make sure the person is alert. Before you feed anyone, let the person be alert. At the oral preparatory stage is very important. Let the person be alert that food is about to enter their mouth and they have to be ready to accept the food. So we have to prepare some of them to, if you are supporting people like that, you have to prepare food in different textures. Some of them, the textures have to be thick enough to be able to swallow. Textures like maybe food like cocoa, awuza cocoa, more cocoa, corn porridge, and then can take custard or brown oats. Yeah. And so we have to watch out for the stress whenever we are feeding the person. If the person is distressed, they don't feel like eating, we have to also be vigilant and alert as caregivers. We have to be patient and supportive. I know feeding someone is not easy. Feeding someone is not easy, but we have to be very supportive. And the diet has to be highly balanced. Highly balanced. We must have the rainbow food where we have our proteins, carbohydrates, vegetables, everything inside of food. Even if it's going to be pureed, all of them has to be present enough to let the person have good nutrition. So foods to eat and avoid with difficulty. If you have some difficulty with swallowing, please kindly avoid, biscuit, high crust food, biscuits. See, that's why I said that when we come into this session, I want you to have your biscuit or anything with. If you have biscuits, when you put it in your mouth and you bite into it, you really like it just separates and scatters in your mouth. You have to chew and let the saliva bring them all together. It takes a while before the saliva will put them together into a bolus before you swallow. With some people that are the aged, they with some conditions like stroke and the aged, they might not have that kind of ability to do all that kind of thing. So before you realize the struggle reflex is the swallow reflex is triggered, and then then the food just goes down scattered, and they will start coughing. So that's why we are saying that foods like biscuits, we don't encourage them. But when we take in foods like groundnut too is not encouraged, and nuts are not encouraged. So we have something like soft food, pureed food, smoothie, eggs. Eggs are very soft. You can swallow them easily. We encourage them to eat this kind of texture. So these are some of the modified textures I'm talking about. But anytime you have these modified textures, I want you to make it nutritious and now a balanced diet for the individual. So, but before I go away, I was supposed to show you a video of dysphagia. So please let me stop and go. Okay, I'm stopping my slide and show you share my dysphagia slide. Please, I'm coming. So it's very short. I hope you can see. So this is normal swallow. So these are some of the imaging that I say you do. But this is when dysphagia also occurs, you realize that the person is swallowing several times. One swallow, two swallow, swallowing again, because you see there's still some residue here. So food is stuck. Food is in there. Some pieces of the water is in the valleculae. We call this side the valleculae. It's just there. So you realize that the person is swallowing several times. So when you chew biscuit like this, like if someone has difficulties with swallowing, some of the pieces of the food can get there like this, and the person will keep swallowing, and you realize that the food is also entering the trachea here. The food is entering the trachea, which is also bad, and it's not good. So this is also an example of dysphagia, but this one is mainly this is mainly another abnormal swallow coming, another abnormal swallow of dysphagia. So I hope we get it this time around. Let me play it again the last time. So normal swallowing is happening. which is very easy and fast, it goes down. But when we look at, okay, so I'm going back to my slide. So I'm home. I think I'm done with my lecture. So key takeaways: dysphagia is difficulty swallowing. It can affect anyone at any age. So early identification and management are very important. Safe eating, better health. Safe eating is equals to better health and quality life. Thank you. Any questions? Thank you for listening. Any questions?
Thank you so much, Esther. We appreciate everything that you've done for us and teaching us about dysphagia. So please, I saw some questions in the chat box, and if you have any comments, concern, question, whatsoever, I know those on our YouTube channel also are watching. So you can write it there, or you can also write it here. And whichever way, we would read it and we'll try to find answers to all of this. Let me see what we have currently. Okay. So Doc was asking something. I think you mentioned all of this, but you let me take my time and read them one at a time. So we see if you've not mentioned it. If you need to go over it, that would help us also remember. That would be helpful. So Doc's first question is that is the automatic closure of the airway, that's the apnea, affected when we force children to eat, like closing their noses and pushing food in their mouth or even medicine?
Okay, so I think it looks like our people knew science before we go to do, because you know that for swallow to happen, there must be a cessation of breath. Because if you, whatever that's in your mouth, when you get seizure of breath, everything inside must go down, whether you like it or not. So I think our grandmothers, and I think they know some bits of science, so they were applying it. So yes, the automatic closure of the airway, it doesn't affect it. Okay, you are doing it manually. So when you do it manually, and then they also do, like when you do it manually, automatically it also happens. So swallowing goes down. Okay, please, have I answered the question?
I think so. I know there are other people here. Z is also here. Zara, would you want to add something to it? Or if you're fine, then I continue to my next one. I like putting her on the spot. Okay, since she hasn't, oh, she would not be able to. Okay, you let me wait. When she's ready, she would say something. I'm sure if she has something, Zara would show by hand. Okay, the second question is that is dysphagia one of the reasons why some children drool a lot, especially the children with CP?
No, please. The children with sleepy is a different thing. This time, the excessive drooling I talked about was when a child has swallowed something. Okay, so TB is part of their condition, but this is a child who is normal and has everything going on well, and all of a sudden they are drooling very excessively. Then we'll say that, okay, then the child has swallowed something and we have to check it out. So it's mainly the excessive drooling is mainly for maybe a typical child or a typical adult that has swallowed something that is not supposed to be there. But with children with CP, the condition comes with drooling already. Yeah.
Okay, thank you for that. All right, so the third question has to do with can dysphagia affect speech production?
No, please. as we saw in the diagram, realize that the speech pathway and the swallowing part, they are different. So swallowing happens to be with feeding. Speech is also a different way, although most of the oral phase and the things, the organs that are uh, that are part of swallowing, which is the tongue, the teeth, they are also part of speech production. Like they also help in speech production, but they also help in swallowing too, which is the oral phase. But it's with two different things. We realize that when we are swallowing or we have something in our mouth, we cannot talk at the same time. If you realize, so there are two different things in separate denominations. Yeah.
Yeah, separate denominations. That's true. Okay. So then our fourth question is that how do we help children who are drooling excessively? How do we
Okay, so which is if it's with the CP condition. Okay, so with the CP condition, the speech therapist can help. I remember that I helped one child who was drooling and was having CP. So she liked to chew gum, and anytime she chewed gum, she doesn't drool more. So she's able to control her drooling. So you see, the saliva is always being swallowed anytime. So when you go to speech therapy, those who do not like chewing gum, would also she's like a teenager. So the person I'm talking about is a teenager. So we use the gum and it worked. So anytime she chews the gum, she's swallowing. And sometimes you'll be prompted to swallow anytime you feel like there's saliva coming out. You'll be prompted in therapy to know and also have your handkerchief or tissue around. Anytime you feel like drooling is going to happen, try and clean up for socialization purposes so that you wouldn't be drooling. Most of them, most of the people I dealt with were more teenagers, so they were more aware, unlike the children. Because when you keep prompting children, they will keep drooling. But as they grow and mature, they realize that it's part of their condition, so they have to do something about it. So you keep prompting them whilst they are young. That anytime you feel that there's drooling coming, try and swallow. You have the prompting has to be like every time swallow, 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 and then you wipe their mouth. Like they have to wipe, they have to get that awareness to wipe. But chewing gum also help, which is one child that I worked with, but I don't know whether the chewing gum will help any other children. Yeah.
Okay, okay. So then with that, we move on to the next one. Okay, so Doc is asking that when will speech therapists in Ghana learn how to do laryngoscope, laryngoscopy? Sorry, laryngoscopy. When would
Okay,
you
so okay. It's
learn?
manual. We have to go and learn and add up to this our knowledge. We have to sponsor ourselves and go back to school. Because even in Ghana, dysphagia is not treated by every speech therapist. Every speech therapist have their own specialization. So we can't say that you meet this speech therapist, then you just bombard her with dysphagia. No, no, no. Everyone has their specialization. Not everyone in Ghana can actually attempt a dysphagia case. So we would actually refer you to anyone who is more experienced than net to handle. Like I said, dysphagia kills. So not all of us are ready to handle a case that will kill you. So, but those who are interested, like I said, will have to go and gain more knowledge. And it's like an area on its own. And it looks like it's gearing towards the medical aspect. So you have to learn more and gain more experience in that area. So we'll go and learn. We'll go and learn. Don't worry. When the money comes, we'll go.
So then she adds a follow-up question to that apart from Mission Pediatrics, where else can they be referred? Because definitely
Okay.
Ghana is big. So where else can
Okay. So we can go to Kolebu. Yes, Kolebu Teaching Hospital. We have a speech therapist there and who can help. And Jamila is there. She's very experienced with dysphagia cases. And we have Clement, who's used to be my lecturer. He's also good with dysphagia cases. And with these two people, they are the ones that I know in Ghana for now. But sometimes we do have Jane. Jane Dawson coming down here. I think she'll be in next month in October, who's also good in dysphagia. So when she comes in, some dysphagia cases are pushed to her. But we are all learning, and some we have some SLTs too in the second cohort. We have Vic, we have Nee, all of them who are also learning the dysphagia as things too, so they can handle it. But we are not that much, but we are learning and helping out. Yeah.
Thank you for learning. We never stop learning, do we?
Yeah, we never stop learning.
I like that. Okay, so thanks for the prompts, Nashika. NZ. Okay, so Patricia is asking, let me read. I don't know whether it's a question, but let's see. Please, there's a 66-year-old woman who wakes up at night and sometimes vomits and experiences difficulty in breathing whenever she eats late. Is it possible that she's having dysphagia?
Okay, so if she's having symptoms like that, I'll tell her to first of all go and see the doctor first. Go and see the doctor if it is something that is really worrying you. But I would say that maybe she could have some acid reflux because you are eating in the evening and whenever late, yes, acid reflux could cause you to feel like waking up and trying to vomit. So going to the ENT department, they could, when you tell them the symptoms that you are having, they can help you out. Yeah.
Exactly. Thank you. So, Patricia, please seek medical help. Let them examine her, and then we can know what next to do in getting support. So now Shika is also asking you to go over the management options or procedures. Please go over it for us.
Okay. So let me share my slide again.
Yes, please.
Okay. I'm trying to go back. Sorry.
No problem.
Okay. So I started with, okay, so how my dysphagia is managed. First of all, I said that you will be assessed first. Assessment starts, you'll be assessed first, and you have treatment with speech and language therapist. Your food that you eat have to be modified into fine textures or smooth textures. And then with speech therapy, we can teach you some compensatory strategies, but it's mostly with people with head and neck cancers that we can teach the compensatory strategies. And then medical and surgical options too in some cases. So with the management, like I said, assessment first. An evaluation, like thorough assessment, has to be done on you. So it's either we are coming to your bedside or whenever you come, we'll have to do have you look at your facial muscles, whether there's any uh, paralysis on your face. We can judge from that. We have some your vocal quality is not like a way it used to be. I said that when someone has dysphagia, there are some of the symptoms, and the symptoms is I know if you have experienced this, like you just choked on the food and you just cough and you cough so much that after that you realize that your voice has changed. That condition, that person has it all the time, like it's frequent. Yours is just one time thing, but I'm just trying to explain why that thing that you go through, if that person has it all the time with their voice change, is also is a symptom of dysphagia. And then you realize that your swallowing is continuous. You swallow several times, and we will test you with different foods. We'll test you with water, we'll test you with pureed food, we'll test you with my biscuit, like different food consistencies, and we'll ask you some questions like taking your history. And then and after that, if you have to go further on, you go through this flexible endoscopy evaluation where you have this flexible tube it has a camera at the tip to go to your nose, go down to check what is happening when you swallow, or you have the barium swallow test, which has to do with a dye, and then you see the imaging. I think that's the last thing that I showed with the skeleton, that's something like that. So For the management, why, like I said, management and treatment, it depends on the symptoms that you presented at the hospital, or your age or the general health of a person. So I gave an example that when the child presents with fever and has trouble swallowing, it could be a sign of infection. And this one, the doctors are the ones that treat it, or the ENT doctors, they will give you some medication to make it go away. Or if a child has swallowed an object, and some of the symptoms of swallowing an object is what? The drooling, excessive drooling, which is a child who doesn't drool, but all of a sudden they are drooling. We know that then the child has swallowed something, and you realize that when you try to feed a child, they are trying to avoid food, or there's this gagging effect. We should try and go and look at it. So if something like that happens, managing this one, the child there will be an endoscopy to remove that object. And this is done by the ENT, not the speech therapist. So the object will be removed and the child will undergo anesthesia before that thing will be removed. And this is treated as an emergency case. The moment you get to the hospital and you just say this, you are just going to theater. And another way of managing this is where the esophageal stricture, where we find that this side where you are swallowing the esophageal, that place is very narrow. So we'll have to do two surgery. There will be some dilation to allow food to pass through well. And all this is done through an evaluation that is done to see this is either through the oh sorry, is that through the endoscopic or the barium test before we can see that, okay, something like that is happening. And then the chronic dysphagia, which is either by the stroke, which happens due to some nerves in the brain, or the brain stem or something is dysfunctioning, which is causing dysphagia. And so when this thing happens, sometimes if it's very severe, we'll resort to tube feeding, or modifying textures can be done. But with the therapist and doing the exercising and compensatory strategies is mostly with head and neck cancers. Yeah. And then cerebral palsy too. So that's the managing aspect. Is it okay now?
I think Nashika will tell us later as we go on, but thank you for going over it for us. Yeah, I appreciate you so much. Okay, so Ramatu says it's a good presentation. So did David. And Ramatu continues to ask a question. It says that some of our children with autism eat very fast. Sometimes they don't even swallow, and they will add more. They would add more. Can this cause dysphagia?
No, please. No, please. It
Okay.
cannot cause It cannot cause dysphagia. Even when you look at the video, you realize that the swallowing happens so fast that we can't even pause to see what actually is happening. If you actually saw the video I showed about swallowing, it's so fast. So you think that, oh, they're actually swallowing. Swallowing is taking part. But when I spoke about the causes of dysphagia, autism wasn't part. I mentioned some neurological aspects and cleft and other things. So I didn't mention autism, and eating fast is not part of it, except when you eat fast and you're talking and you get choked and you cough. That one is different. But eating fast is not a cause for dysphagia. Yeah.
Okay, so yes, that here. Thank you for that. Now, let me move on. So, yes, Doc also confirmed that the symptoms of the 66-year-old could be due to a reflux. So please get help. Yes, Isa says, please, a 40-year-old man has been suffering from sleep apnea for 28 years now. What could be? Okay, so what could probably be the issue? And it only happens it only happens when he's about to fall asleep.
Okay, so sleep apnea is not my domain. So maybe a medical doctor can actually answer these questions.
Okay, like that. It's good when we stay in our lane, right?
Yes, please. Yes, please.
So please, Isa, please seek for clarification on that. She is a speech
Yes,
and
please.
therapist,
Yes,
so
please.
she can help you to a point, but probably this one is not her specialty, so she cannot
Not
comment.
at all. Not at all.
Thank you. Thank you very much.
Yes,
Okay.
you're welcome.
Prince says that how can we differentiate between orophageal and esophageal? Pardon me if I'm not pronouncing the words right. Um, okay, so how can we distinguish between these two dysphagia during history taken? Does it differ?
Okay, so first of all, the oropharyngeal phase is different from the esophageal phase.
That's the
And
correct.
all of that space, when I was talking, I was saying that they are both involuntary. So that means the ones that is the brain that is in charge of these things. The nerves there, the nerves and the brain stem, they are in control. If something should happen to any of these nerves, or in the brain stem or any other thing, it can cause the part of the brain that is part, responsible for dysphagia. It can the part of the brain that is responsible for dysphagia, and if it's the brain stem or the nerves, it can these places, the nerves there could be affected. So with oropharyngeal phase, if you look at the video that I showed you, it's a different place, which is like this side of my body. Yes, and is whatever happens there is different because maybe the soft part. Let me use my let me use my picture. I'm coming. Let me share my.
Take your time, please.
So I'm sharing my.
So as she prepares to share, if you would like to put up your hand and ask a question, please, the floor is yours. You can just use the raise hand button and you would be allowed to talk. You can ask, comment, do anything. If it's ready, Esther, you can go ahead, please.
Okay, so this part is the esophagus, right? So remember I was talking about esophagus. This side, I was talking about this the esophagus being narrow. So that means food is not able to pass through easily. It's a different dysphagia from what happens here. So what happens here, I talked about pieces of food being in a vallecule. So this place is an oropharynx dysphagia. So this place is a different dysphagia because food pieces can be here, pieces of food can be collected here. Okay, and if pieces of food is collected, we realize that the person is swallowing multiple times to make sure the food is gone, like it's gone down. That is different from maybe an esophagus here being narrow and food is not going down. Okay, so if food is not going down, maybe there will be surgery to dilate this side of your throat to make food go down easily. And also this part is also part of the oropharynx, yes, when food is going down the trachea, your vocal cord is here. So when food, some of the pieces of food gets here, it's also going to cause aspiration, which is another oropharynx dysphagia, which is different from the dysphagia that will happen here. So if the nerve cells here around here, if peristalsis is not happening, as I showed a video where there's some logoligi movement here, it's not able to push the food. That means cells are being affected. Okay. So dysphagia here, we have different nerves that are controlling things here. We have different nerves too that are controlling here. And this side too, if this soft palate is not closing, food can also pass through this side. So this side has different dysphagia happening here, which is different from dysphagia happening in the esophagus. Please, are you okay now? I can show you the video.
we wouldn't
Oh,
mind showing us a video so that probably the person gets
okay.
more enlightened on it.
Where's my video?
So
Okay.
as the video is coming,
Okay, so I showed this skeletal video where normal swallowing, we realize swallowing is very fast, like within a twinkle of it's just gone down like that. But I look at the second one, you will see the oropharynx here, dysphagia here. And then we have another one going down, we have another dysphagia coming in, but all this is the oropharynx. But the other one, which is the peristalsis happening here, I didn't have a video like that to show that, okay, there's a structure of food not going down easily.
In this video fluoroscopy in a lateral view.
Sorry. Please, does it answer your question?
Prince, I know he would comment in the chat box. So, but he also requested that we show the video. So thank you for showing us the video. Prince, I hope you are answered. If you are not, please do let us know. We'll try our best. All right. So Doc has given us some contact numbers for the question that was asked earlier concerning sleep apnea. So she's saying that you can go to Kolebu to see a specialist. That person can give you the needed help. And then you can also reach out to Love Hill Clinic or Franklin Medical Center. The number is also there. Please check it out. Okay, so Wilhelmina is asking a question. Wilhelmina is saying that unfortunately she's just drawing in, so she's not sure whether it's been said already, but her son is speech delayed. He is 3. He is able to make sounds baba, baba, mama, etc., but nothing that is intelligible, so it doesn't make sense. He's getting support with speech at school. He is able to eat and swallow all right. Does he need a swallow test? Is there anything else that she can do to assist him?
Okay, so well, Mina, your you can bring your son to Missions Clinic for assessment. We'll see the speech therapist and then we'll move on from there. But doc will assess your child first, then will be passed on to us. Then we'll move on from there. So so he said he's getting speech therapy to our school. Okay.
Yes, getting
Eating and swallowing is all right. Does he need no. He doesn't need any swallow test if he's eating all right. So if you are supporting him, I think the speech therapist working with your son will give you some strategies that they are using, some of the interventions. So maybe you could ask the speech therapist, what interventions are you doing so that I will replicate the same thing at home. Parents must also be part of the therapy system, not only therapists. We must all work together. So let's ask our therapist, what are you doing with my child? So that when I come home, I can repeat the same thing. That's the nicest way you can support your child. And I'm telling you that whatever intervention that your therapist says to you, let's try to do it morning, afternoon, evening. Let's do it and practice it more. Because the more we do it, the better our child will get. But if the therapist sees your child just 1 hour, it is very short for the child to know a lot of things. So you have to be working with your therapist together, know what your therapist is doing so that you do the same thing. And that way, progress will be very fast. Please, is that okay?
Well said. Well said. Thank you. Thank you so much for that, Esther. Okay, so Prince is adding something up. Prince says that considering the neurological conditions like Parkinson's disease, um, considering that it often contributes to swallowing disorders, how can we better understand the impact on dysphagia and improve early detection approaches, particularly in primary care, school, or even in the community. So what are some of the things that you can do?
Okay, so parents, like Parkinson's is also one of the neurological diseases. So, and it's a condition that causes problems with movement. So, parts of the brain, the neurons of the brain, they are getting damaged, they are getting weak, and eventually die. So, it's going to affect the person who has, it's going to affect movement of the jaw. First of all, like I said, movement is considered. And we know that we have to chew to swallow. We have to chew to swallow. And if this person is not able to chew, the nerves involved in chewing is getting damaged, is getting weak. It's going to affect movement, first of all. And then swallowing too, we have nerves that are in control of nerves that are in control, and they're also movement. So Parkinson's also dysphagia happens when these nerves are not working well. So for early detection, whenever I think if there's a diagnosis of that this person has Parkinson's, automatically we can say that they might have dysphagia. So they must go through an assessment. We have to assess this person first. We will know the kind of dysphagia they are having, whether it is the pharyngeal dysphagia or the esophageal dysphagia. And for to assess for primary care, if someone has Parkinson's and has the diagnosis of Parkinson's, um, the doctor would actually ask questions about their, I think, everything, their history and how they are eating and everything. So if there's there's an answer like, okay, some parts of some struggling with dysphagia, I'm sure they would refer to the better personnel or people like speech therapists or hospitals that do deal with dysphagia. And Kolebu, like I said, you can go there. In school like Parkinson's is, I've not seen it with children. I know it's mostly adults. So with the community settings, you can go to your nearest healthcare. If you are diagnosed with Parkinson's, I'm sure the doctor will make referrals if there's any sign of dysphagia with a person. Please, does it answer your question?
Okay. I think so. All right. If there are no more questions coming in, then this will be a very nice time for me to also share something with you. Yes, we did talk about our webinar, our yearly or our annual webinar that we host, where we tend to bring you the professionals and all that in their varying fields. And this year, we will be having it in November, as earlier shown on our social media handles. We would be having our special education and inclusion webinar this year in November of this. So we have like 2 months. The flyer is being shown to you. And from tomorrow, oh, nice. The flyer is on your screen. Fortunately, this year we've gotten help in terms of sponsorship. And so, as part of our 10th anniversary, Mission Pediatrics, in collaboration with Craft Education, is coming up with a special education webinar. And our webinar for this year is themed. I would want to get it right. I don't want to mix anything up. So yes, it's themed Strength in Diversity, Education Without Barriers. Strength in Diversity, Education Without Barriers. We're going to have a whole lot. I saw the theme and I was like, wow, that's a lot. Please do tell others that registration, or we're going to open up registration very soon. As such, we would need you to to confirm participation by making payments, as that would validate your spots in there. The early bird is also there, in addition to if one would want to just take one webinar out of the 8 that we would be having, that is also there. So this is our webinar. The link and all that would be shared with on all our social media handles. So please, you can be a part of it. And as said, the early bird rates and things also have been mentioned in there. Do tell a friend to tell a friend. Those in schools, those in varying places, please make sure you are a part of it. I see Martha's hand up. Martha, I think I need to ask you to unmute. Please unmute, and then you can share with us what you have.
Good evening, Ida.
Good evening, Martha.
I thought you said you have sponsors for the special education inclusion webinar. So why this early bird and others?
I like the question. Yes. So this year we've been sponsored, and unfortunately, our sponsor is just one. As such, if you compare the rates this year to the previous one that we had last year, you would see there is a change. There is an appreciable change in there where it's been reduced to, like, it's been slashed half. So you're getting half of the cost. So it's Donkomi. The Donkomi sale is up. So please do tell a friend to tell a friend. And I know your school would like to participate. So Martha, please tell your people that they should quickly register. You can even register for one, just as we did for last year. We opened it up where people can register for one of the sessions. We also have that same package this year also. So if you'd like to just take one or two, it is opened up. And then when you are registering on the link that would let you have, please click on the ones that apply to you, the ones you would like to register for. We are opening those sessions up for you. So yes, this is about our special education and inclusion webinar that is sponsored by Craft Education for this year. So yes, please, why don't we at least show some appreciation for Craft for helping us to slash down the costs. You can show a reaction, eh? All right, so that's the first one that we have in there. The other one is that we launched Hubeta to you. And yes, we are going to help you understand more about Hubeta. We're going to help you get to appreciate you better. And we're going to change Hubeta's name, but we'll change it and announce it to you later. But for now, Hubeta is up. So for this webinar that we've had, and our previous webinars that we've had, and we are still populating it, we are giving you more. We would want you to have support at your various points of work, of home, or anywhere you can find yourself in this world. Hubeta Chatbot is there to assist you. So let's say you find yourself somewhere. You've heard about dysphagia. You don't even know. You want to find out what to do, how to do it, and the whatnots. Please, the link has been shared in the chat box right now. And we have the QR code right in front of us. So please do scan. And if you have been able to scan, please give me a thumbs up to it and let me know that you've been able to scan and then you've said hello to Hubeta. With just a hello, we get to know if you are there or not. So how many people have scanned? Let's see. Fastest fingers. How many have been able to? How many have been able to? How many? If you are not able to scan with your phone, please, you can just click on the link in there. And then you would be able to have access to it. So the link has been shared. Godfred has shared with us the link to Hubeta. So you can just click, say hello, and then you just go on, have your chat, converse with Hubeta. Who has been able to do it? Today I don't have my fastest fingers in. Oh, Bella, you've been able to do it? Oh, Rosie says she's been able to do it. That's good. That's good. So Bella has, Rosie has. Oh, nice. I have some fastest fingers here. Yay. Who else has been able to do it? Let's see. Let's see. Let's see. Let's see. Want to see the first 5 people who would be able to do it. Ekia, nice, 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 nice. Ekia has been able to do that also. Ramat, have you been able to do so? Oh, Sofa says yes. Techno says they've been able to do it too. Nice, 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 nice. Oh, Esther has been able to. Good. Awesome. Awesome, awesome, awesome. So yes, please. This is a gift from Mission Pediatrics to you. We are bringing support to you in the comfort of your home. Whatever questions, comments, concerns that you have, please do share with you better. And if you have any whatnots, it would link you to us. Then we would be able to provide you with the needed help. That's we can do so. Oh, Abna also said she was able to do that. Thank you, Abna, for being able to do so. Awesome. You guys are great. You're too good. You're too good. You're too good. So please do not keep this to yourself. Just as we always say, tell a friend to tell a friend. So do share with others also. Let them have access to it. Let them use it. Whatever thing that you need in whichever form. If you have feedback, do send the feedback to us either on info@missionclinicgh.com, or you can just send a direct one to ida.brown@missionclinicgh.com, and then we'll work on whatever concerns that you would raise on our Huberta chatbot. Okay, so if we have nothing more, please, our webinar is coming up in November. And since Martha knows the difference in pricing cost, I'm glad. We would say the link is going to be shared. So as they always say, share the link, share the link, share the link. Please share the link. Help someone else get to learn. Help someone else to gain knowledge. You can, the thing is, it's open for everyone, for parents, for teachers, for everybody. Everybody, whether you are in the health sector or not. This year, it's awesome. The speakers, I'm done talking. When I talk too much, it's no good. Please have a good evening. Thank you for joining us. We appreciate the fact that you came. Thank you so much for being here. We have the link to this video and our other ones on our YouTube channel. That's our Parents Roundtable. If you have anything that you would like to learn, please go there, and then you can have access to it. It's for you. Thank you, and do have a great week. Bye. Thank you all. Thank you all so much.
Bye-bye.
Bye, Esther.
Bye.